Okay, thank you. Uh, Scarlett will join us a little bit later. So let's. And one question. Yesterday we had a video on in the slides. Did you hear the uh, voice of the video clearly? Okay. So that two problems are solved now. Yesterday, no, sorry, on Tuesday, we discussed the musculoskeletal tissues. And actually, the musculoskeletal tissues were what we discussed on Tuesday. Nervous tissue is not part of the musculoskeletal tissue, but since it is the reason why the musculoskeletal tissue works, and also when you want to design exoskeleton or myoelectric prosthesis or anything that connects to the human body that depends on the human intention for its movement, you must work with nervous system. That is why I included a brief explanation about the structure of the brain system for you to be familiar with it. And then in future, in one appropriate time, I will explain the molecular mechanism of impulse generation and transmission in brain system. So if you want to create anything that wants directly connect to brain system and to nerves, you will be familiar with the molecular mechanism and how it works, and that is necessary for that knowledge. So the physiology, which is very complex, will be someone in future. But now we will have a brief review of the structure of the nervous system and how, briefly, how it works. Nervous system has three connected sections. The first one is the receiver or the sensory input. This part is the interface between our body or our nervous system and the environment. For example, the skin touches the environment and you can feel everything around your body. Your eyes sees the environment. You can hear with your ears, you can smell with your nose, and you can taste with your tongue. And these are the sensory inputs into your brain. We have another sense that is called deep sensation, and that's a sensation of the position of body parts in the space. That is an involuntary sense. The other senses are voluntary, except for hearing. Hearing is always involuntary. You hear. Even if you don't want, you cannot shut down your ear. But the other senses are voluntary. You can smell or not to smell. You can taste or not to taste, or you can see or you can close your eyes. But for deep sensation, you don't have any choice for it. There are some sensors in all over your body around the joints that can sense the tension in the muscles, in the tendons, and also the position of the joints, the degree of motions of the joint, and they send this information to a part in the brain called cerebellum, and it is processed there, and your brain knows the location of each part of your body. And without that, you cannot stand still or you cannot walk correctly. And it is a very important sensation, but we usually do not include it in the uh, sensory input because it is an inside sensation, not outside sensation. So sensory input gathers the information. Then this information is sent to the brain. Brain itself is the processing center for our nervous system. Every information is gathered in the brain and processed or integration. And then based on this processing, a response is prepared. And this response is sent to the effector organs through nerves. We call this response a motor output. So a sensory output enters the brain, is processed, and the response is sent as motor output to the effector organs. The effector organs are usually muscles. Anything you do are performed by your muscles. That is why sensory system is so integrated with the musculoskeletal system, because without nervous system, your musculoskeletal system doesn't work. All the processing in our nervous system happens in a part called central nervous system. Central nervous system is formed by the brain and the spinal cord. Outside brain and spinal cord, whatever we have, whatever nervous tissue we have is called peripheral nervous system. So central nervous system is located in the skull and in the spinal column. But outside the skull and outside the spinal column, whatever nerve we see, whatever nervous tissue we see, is part of the peripheral nervous system, PNS. Central nervous system is abbreviated as CNS. And again, this is one of the abbreviations that is more famous than its full words. Our nervous system is formed by several cells. One group of cells are supporting cells. They are in the nervous system to support another group of cells. We don't want to know anything about them because they are not important for our job. But the main group of cells in the nervous system are called nerve cells, or more famously, neurons. This is the same word that is used in AI today for neural network systems that they are creating, and each node in the neural network systems is called a neuron. This is the same word, but it is not the same. And that node is far from a neuron in our nervous system. You will see later how it's different. Neuron is the basic cell that forms our nervous system and is responsible for all the nervous activity in our cells we have in our body. We have billions of these cells in our brain and spinal cord. The main property of these cells is their excitability. They can be stimulated, and once they are stimulated, they process this stimulation and then create a response and send this response to another cell. This is their main property. Neurons are unique cells in our body, both based on the shape, the size, and their longevity. Once you pass the age of 8 and 9, the number of neurons in your body is finalized. And these neurons will not regenerate, will not divide, will not create new neurons. And then, until you die, the number of neurons in your body remains the same, unless due to a disease process, some of them are destroyed. But new neurons are not created. So the neurons in your body live with you for the whole life that you live. They cannot divide, and also they use a lot of energy because they are always functional. Even when you are resting, they are functioning. Your brain never rests. When you sleep, the brain is functioning more than when you are awake, because it has to reorganize the information that was gathered when you were awake. So it is functioning, but you don't uh, sense it. For this function, when we discuss the molecular mechanism, you will see the function of the neurons needs energy. So when they are functioning, they use a lot of energy. And this energy only comes from glucose. Our brain needs pure glucose. And one of the major users of glucose in our body is brain. That is why when you feel hungry, the first part of your body after your stomach that is alarming you that you are hungry, the first part of the body that has problem in its function due to being hungry is brain, and you lose your concentration. Each neuron has a cell body like any other cell. All the organelles we discussed before are present in the cell body. All cell bodies of neurons in our nervous system are located in the central nervous system. We don't have any cell body in our peripheral nervous system, with few exceptions. So ignore those exceptions. Consider all the cell bodies in our central nervous system. The plasma membrane that is covering the cell body has a unique function. It can accept the nervous impulses from other cells. From this cell body, several projections appear, and these projections are the main functional part of the neurons. These projections or processes are of two types: dendrites and axons. Dendrites are short projections or processes, and they branch into several branches. But axon is a single process. Their function are different. Dendrites are the accepting part of the neurons. They connect to other cells and they are receivers. They receive the nervous impulse and transfer it to the cell body. And I said the membrane of the cell body can also accept the impulse. So all this area can accept the impulse from other neurons. Once they are stimulated, they transfer this impulse to the cell body, and this impulse ends here. Cell body performs some processing on it. We don't know the mechanism of this processing, but something happens in the cell body, and based on this processing, a response is produced. This response is transferred to the axon. Axon is a single process. Each neuron has only one axon, but each neuron can have thousands, hundreds, or thousands of dendrites, but only one single axon. This axon exits the cell body and transfers the response produced by the cell body to the other cell. So axon is a conveyor of impulse away from the cell body. Dendrites brings the impulse toward the cell body. Axon takes it away. Although each cell has only one axon, but at the end of the axon, it branches into several smaller branches. Sometimes one axon can have 10,000 branches. It means it can attach to up to 10,000 other cells. These, the end of these axonic branches are called axon terminals. I said all the cell bodies are in the central nervous system. Beside the cell bodies, some axons and dendrites are also present in the central nervous system. But in peripheral nervous system, we don't have any cell body. So what do we have in peripheral nervous system? It is only axons. So all the nerves you see in the body, all around the body, they are formed by axons. So it means that if a cell body is in my spinal cord and the axon forms this sciatic nerve that goes down from my lumbar area to the tip of the big toe, it almost travels 1 meter. So the length of axon can be as much as 1 or more than 1 meter. And it means that the length of this cell is maybe as long as 1 meter. Around our axons are very thin. To support them, we have a cell that circles around the axons like an onion, like onion layers, and covers the axon and supports the axon and provides nutrition to the axon because it is very long, and sometimes bringing the nutrition from the cell body is difficult. So these cells called Schwann cells, where is it? We call them Schwann cells. Here, Schwann cells. They provide nutrition and also support and protect the axon, but they have one more important function that we will discuss later. Neurons can have different shapes. You don't need to memorize them, just be familiar with their different shapes. You are familiar with electronics, and in electronics, when we have a difference in the charges at 2 points, a current will be created between them. The difference in charges is called voltage, is measured by voltage, and the flow of currents, which is called current, uh, is calculated by dividing the voltage by resistance between 2 points. The same thing happens in our body because our body is full of charges. The whole body has neutral charge, but at surfaces, there may be a difference in charges. In electronics, when you are talking about the current, you mean the current of electrons. When you have a potential difference between 2 points, it means that there is a difference between the charges between the 2 points. And if the resistance allows the movement of electrons between these 2 points, electron move from the negative charge to the positive charge. But the positive charges doesn't move toward the negative charges. Always the electrons are moving in electronics. But in our body, it is a little bit different. In our body, instead of electrons, the positive ions move. So when we are talking about the current of electricity in our body, we are talking about the movement of positive ions, just opposite to the electronics. And when we are talking about the resistance, we mean the plasma membrane, the membrane of the cell, which provides the resistance between the two parts. When you look at a cell, the whole cell is electroneutral. But when you look closer and you look at the membrane, just a few, maybe microns, maybe nanometers around the membrane, there is a difference in charges. One side of the membrane is more positive than the other side. I'm not going to discuss the molecular mechanism for it. We will discuss it in a separate session because it is a long discussion. But due to several molecular mechanisms, the potassium and sodium ions are not distributed evenly around the cell membrane, just very close to cell membrane. If you measure a little bit farther from the membrane, there is no charge difference. But just across the membrane, very close to membrane, there is a imbalance between the distribution of sodium and potassium ions on both sides. So outside the membrane is positive, inside the membrane is negative. And if we measure this difference in potential across the membrane, it is minus 70 millivolt with negative charges inside and positive charges outside. This minus 70 millivolts is called resting membrane potential. When the cell is not stimulated, we have this minus 70 millivolts as the resting membrane potential. And in this condition, we call the cell membrane is polarized. Inside negative, outside positive. The difference is minus 70 millivolts. But if the cell is stimulated, this charge will be reversed. So when it is stimulated, when it is stimulated, outside will become negative and inside will be positive. So the cell membrane now become depolarized. It was polarized at first, now it becomes depolarized. And this is called the action potential. And this is the nerve impulse. When this happens, there is about 100 millivolt change in the potential in the membrane. The potential changes from minus 70 to positive 30. And now outside is negative, inside is positive, and we call it depolarization. This depolarization, which happens, takes a very short time, less than a millisecond. And then gradually the cell membrane returns to its original condition. So from depolarization, it becomes polarized again, or repolarization. In the nervous tissue, this repolarization continues a little bit more, which we call hyperpolarization. The potential will become more negative, maybe minus 75, and then gradually returns to minus 70. And now the membrane is ready for another impulse, another action potential. This is a cycle of action potential: resting, depolarization, repolarization, hyperpolarization, and again resting. This is called one nerve impulse. When it happens, and it takes, as you see, it takes a few milliseconds. So when it happens at a single location. But we have a long axon, and it must travel along the axon. So this travel is called propagation of action potential, and it travels along the length of the axon. First, this area is stimulated. It travels to the next area, and it continues until the full length of axon is stimulated. And the stimulation reaches the end of the axon, which is called axon terminal. We have two kinds of propagations. One is called continuous, the other one is called saltatory. The importance of this propagation is its speed, how rapid it travels along the axon. If it travels slowly, the response produced by our nervous system will be delayed. For example, when you see something, you are driving, you see something in front of your car, and immediately you push the brake. If this immediate response happens because the travel of these nerve impulses is very fast in your nervous system. If they were slow, you would push the brake after you hit that object. So our brain system tries to make this propagation of impulses faster and faster. If the axons are simple and they don't have any myelin sheet, I said myelin sheets cover the axons and they support and provide nutrition, but they have an important function that is here. If the axons doesn't have any myelin sheet, they use the continuous conduction. One part of the membrane is stimulated near the cell body, and it stimulates the adjacent part and adjacent part. And since it is at microscopic level, it takes a long time to stimulate one by one until reaching the end of the axon. So this continuous conduction or propagation is very slow, and we don't like it. If the axons are covered with myelin, which happens in almost all peripheral nerves in our body, these myelin sheets have a specific shape. They are not continuous. You see here, they have gaps between them. The length of these parts of the myelin is usually 1 millimeter. So there are gaps 1 millimeter by 1 millimeter along the length of axon. This myelin sheet is made by lipid because it's formed by the plasma membrane of the cells. So since it is lipid, it is an insulator, and the electrical charges cannot pass through it. So the part of the axon that is covered with myelin sheet is insulated. But the part that is between the myelin sheets in the gaps is not insulated. So the impulse generated in the origin of the axon, instead of traveling by stimulating the next molecule and next molecule and next molecule, it travels by jumping between these gaps. 1 millimeter by 1 millimeter. Instead of one molecule by one molecule, it travels 1 millimeter by 1 millimeter. And since this jumping is very fast, the saltatory conduction in myelinated axons is very fast. And that is why when you are driving even very fast, when you see something in front of your car, your reaction time is enough to push the brake and stop the car. We said the end of the axon branches sometimes up to 10,000 branches, and the end part of each of these branches is called axon terminal. These axon terminals connect this axon to the next organ. It can be a neuron, it can be a muscle cell, it can be a gland cell, whatever it is. The next connection with the next cell is through these axon terminals. And this connection is called synapse. The neuron, if it is between two neurons, like here, one neuron here and one neuron here, the neuron that has the axon here is called presynaptic neuron. And the neuron that the axon connects to it through its dendrites or cell body is called postsynaptic neurons. Each neuron can connect to up to or even more than 10,000 other neurons. So when you have an impulse in one neuron, it can stimulate several other cells. Cell bodies in our brain system are gathered together to perform a similar function. For example, vision, smelling, uh, talking, interpreting the speech, or understanding the speech. Uh, these parts that are formed by a group of cell bodies of similar neurons are called neuron pools. These pools of neurons are responsible for the processing of information in our brain. We have two kinds of processing in our of information in our brain. The first one is very simple. It is serial. The information arrives in a cell, stimulates the cell makes the processing and send the response to axon. Axon stimulates another cell. That cell process the information, sends the response to axon, axon to the third, and it continues until it reaches the final response. This is called serial, one by one. And as you know, this serial response is very slow. But uh, our brain has a unique capacity to perform parallel processing. If our computers could have performed parallel processing, the speed of the processor of our computers would be unbelievable. Our current computers are performing serial processing. They cannot perform parallel processing. We do not have that technology, but our brain has it. Parallel processing means the information enters several centers at the same time, and they all are functioning to process that information and then gather those information together and send a response. It's very simple, simple to understand. I mean, not simple to replicate. Uh, you are smelling a pickle, or you smell a perfume. About that perfume, once you smell it, you remember the first time you smell it, the person who was wearing it, the place you were, and even the affection you sense then. You remember several things at the same time, just but by one stimulus, which is smelling a perfume or smelling a pickle or seeing a pickle. This is because of parallel processing, because several centers are working together, and the brain has this capacity to know where to send this information. When I smell a perfume, my brain doesn't send it to an irrelevant center about a book. It knows where to send it. That is the important part. He knows how to send the information to the relevant centers. A smell goes to visual center, for example. Visual center, the smell center, the maybe hearing center, but other information may be sent to another centers. And that is how the brain can process different same information with parallel processing very fast. And this parallel processing is what makes our brain the human brain. This was a general description of the, I'm very brief, of the brain, you know, the most complex and sophisticated structure in the whole universe, not on Earth, in the whole universe, the most sophisticated structure that the human knows is human brain. And believe me, with all the information, all the technology, and everything we have now, we only know about 10 to 15% about the brain. We still need to know more than 80% about the brain, and we don't know anything about that 80%. That is why whatever we want to do with brain, we are not successful, because we want to add something to brain. We want to add a chip to brain because we don't know how it functions. We perform something very uh, um, simple and very primary, but it is not what we want. We want, for example, to attach a chip to brain to uh, activate the memory, to increase the memory, but we cannot, because we don't know how memory works. Believe me, we don't know how our memory works, where we store our memory. There is a part of the brain that we think is the storage of memory that is called hippocampus in the brain. But we think it is there. We are not sure. Outside the nervous system, so outside the skull and spinal column, whatever we have is peripheral nervous system. And these peripheral nervous system are in the form of nerves. These nerves are distributed all over our body, some of them in the face and cranium, some of them in the extremities and trunk, and they bring the information from periphery to the central nervous system and take back the responses produced by the central nervous system to the periphery. We have a pattern of nerves around outside the nervous system, and this is a structure of the nerves that are exiting the spinal cord. They join together and form the nerves, as you see here. When we are talking about the peripheral nerves, the nerves in the extremities, they are actually collection of axons. Several axons. This is one axon. It is covered by a very thin membrane, and a collection of these axons, again covered by another thin membrane. They form a nerve fascicle, and based on the size of the nerve, several of these fascicles, maybe 1, 2, 3, or more, join together and form a peripheral nerve. These nerves have name. The names we use for the nerves are applied to these nerves. For example, radial nerve, ulnar nerve, median nerve, sciatic nerve. These are the names that we use for these nerves that are collection of several fascicles. When a peripheral nerve is cut, actually we are disconnecting the axon from its cell body. The cell body is in the central nervous system. We are not injuring the cell body. Cell body is there and it's safe. But we cut the nerve, the axons are separated from the cell body. What happens? The part that is away from the, for example, I have a cut in my wrist and my median nerve is cut. The cell bodies are in the cervical area, so they are safe there. And the axon from cervical area up to here is safe. But the axon part that is cut from my wrist to the fingers are gradually resorbed. So this part will be lost. But since the cell body is intact, the axon here begins to grow and regenerate. So when we have an injured nerve, we try to repair it and put it together to provide a path for the distal part of the nerve when it begins to regenerate. And in this way, because the axon degenerates and is resolved by this sheet, this endoneurium, preneurium, and epineurium, these canals remain in place. And if the axon can find its way into these canals, it can regenerate and reach to the final destination. So this is how nerve repair works. Okay. Any question? No. So let me. Do you want to have rest, or you want me to continue? Continue?
Yeah,
Yes.
continue, please.
Okay. The next discussion is about operating room. Operating room always comes with a sterility and a sterilization. First, you need to be familiar with the abbreviation OR. OR means operating room, and we almost never use operating room. We always say OR. And whenever you hear OR, it means operating room. If you are in a hospital, but outside in a general ward of the hospital, and you say OR, it means the operating room department. But if you are in the operating room department and you say OR, it means the room dedicated to the surgery. Okay? But the true meaning of OR means the room that is dedicated to surgery and a surgery is being performed there. When we are talking about the operating room, we have two kinds of operating room, two designs for operating room. Centralized and decentralized. Centralized operating room means all the operating room, for example, orthopedic surgery, general surgery, ophthalmic surgery, ENT surgery, gynecology surgery, vascular surgery, all these surgeries are together in one department and one section. So, for example, there are 20 operating room in that department, and each one is for one subspecialty. In this area, everything is around this operating room. We have pre-operating preparation, we have a sterilizing area, we have storage rooms. They have some advantages and some disadvantages. The advantages for centralized models is, first, the surgical teams can communicate with each other. For example, if you are performing a orthopedic surgery and you have a nerve or vascular injury, you have a vascular surgeon in the other room, and he or she can help you. Or if you need a device from another discipline, for example, sometimes you are performing a nerve repair and you need a device from neurosurgeons or ophthalmic surgeons, a very tiny device from ophthalmic surgery department. You have it in the storage room because all the departments are in the same, all the subspecialties are there. So you can have access to it. And also for for hospitals, they can run the centralized operating rooms with fewer personnels. But there is a huge problem. The level of sterility necessary for different surgeries are not the same. For example, general surgery, all the surgeries need a sterility. But the level of sterility for general surgery, if we use that level for orthopedic surgery, all the orthopedic surgeries will be infected. The level of sterility for orthopedic surgery is here, and for general surgery is here. Since in general surgery, we don't need those strict rules, we don't use them. But for orthopedic surgery, we have to use them. For example, brain surgery, for neurosurgery, we have to use those strict rules for sterilizations. So when all the operating room from different disciplines are in the same area, these disciplines are not respected clearly, and sometimes the infection rate is higher. And also, the area is more crowded because there are many traffic of the personnel in the area, and sometimes the infection rate is higher. Due to these reasons, especially about the infection, current hospitals try to prepare the operating rooms for each subspecialty close to their department and ward. This is called decentralized model. For example, we have a department of orthopedic surgery. They have their own operating room attached to their ward, and the general surgery have their own operating room, and ENT has its own. So we have several operating room departments in one hospital, each one dedicated to one subspecialty. So in this way, the risk of infection is less, but you need more personnel, you need more equipment, the interaction between surgeons. Now, if you have a vascular complication and you need a vascular surgeon, you don't have it. You have to wait for the vascular surgeon to leave the vascular surgery operating room and come to your operating room and start the sterilization again, changing clothes, everything, and it takes time. So each one has some advantages and some disadvantages, but decentralized model is preferred now. In each operating room, centralized or decentralized, in both of them, we have a zoning pattern. We have 3 zones in each operating room based on the sterility and the rules of sterility that must be respected in this area. One area is called unrestricted, which has no rule for sterility. One area is semi-restricted. You have to respect some rules there. For example, you cannot walk in this area with your own clothes, or without a cover on your shoes, or without a hat. But restricted area is the area that a surgery is being performed or the surgical equipments are stored. And in these areas, you need to respect all the rules of sterility. So unrestricted zone is the area that the operating room is in contact with the outside environment. uh, where you enter the operating room, where the patient enters the operating room or is moved from the operating room, where you need to change your clothes. So dressing rooms and lockers, and also the administrative area are in unrestricted zone to allow them to have meetings with other people easily. In this area, as I said, you have no restriction. You can enter this area with your clothes, with your shoes, without any hat. But if you want to leave this area and enter the next level, which is semi-restricted, you need to change your clothes. You need to wear a hat. You need to wear a mask, and you need to change your shoes or have a cover for your shoes, a clean cover for your shoes. So these rules: hat, new clothes, um, mask, and cover for your shoes is necessary for entering the semi-restricted zone. Semi-restricted zones are uh, the area that the patient is prepared after the patient enters the operating room. We have an area that we prepare the patient for surgery. Some medications are administered to the patient. The blood pressure is checked. Everything is rechecked there about the patient. And corridors between the different rooms, different operating rooms. You see them, for example, here, the yellow area is, sorry, the yellow area is semi-restricted. Everything in between the operating rooms, they are semi-restricted. You can walk in these areas. You don't need to wash your hand and wearing the sterile gowns. But if you want to enter the third area, which is restricted area, you must be very careful. The restricted area is where the surgery is being performed. In the restricted area, we respect this area and we try to always consider it restricted, even when there is no surgery. Because when there is no surgery, if we do something in this area that is not allowed during the surgery, we may increase the risk of surgery that will be done after that, after what we have done. For example, if we repair something and we do not uh, respect the rules, so it may cause to infection in the surgery that is done after that. I mean, you may say when there is no surgery in the room, should we consider it semi-restricted or restricted? We still consider it restricted area, even if there is no surgery being done in this area now. So the room that is designed for surgery and also the room that is designed for storing the sterile equipments. Usually we have two rooms for these sterile equipments. One is general room. We don't have in this map. One is a general storage room. When the equipments are sterilized, they are carried to this general storage room. But during the surgery, the equipments that are necessary for that specific surgery are moved close to this operating room. They may not be inside the room, they are beside the room in another room. That this area is the second one is restricted area, because it is in close contact with the operating room in which a surgery is being performed. So if we want to enter this storage area, the second storage area, we need to respect the rules. The general rule for entering a restricted area is wearing hat, wearing mask, wearing shoe cover, having new clothes, washing hands, wearing sterile gloves, and wearing sterile gowns. But these rules are when you want to enter the sterile field of the surgery. When you want to enter the room, the restricted area, but you don't want to enter the sterile field, which is around the operating table. For example, operating table is in the middle of the room. You just want to enter the room and stand beside the wall and watch the surgery, or watch the surgery in the monitor, or talk to the surgeon, but you are away, you are not in the field of surgery. You don't need to be sterile. You don't need to wear glove or wear the sterile gown. The same thing happens for the anesthesiology. Anesthesiologist doesn't wear a sterile gown or wear a sterile glove. He only wears hat, mask, and cl- new clothes and clean clothes and cover on the shoe. So although you enter the restricted area, but you don't need to be sterile to enter it. But if you want to come close to the surgical field to watch the surgery closely, you need to be sterile. Operating room is a specific area that every day is in contact with some hazardous material. Blood is one of the most hazardous materials. It may contain bacteria, it may contain different viruses, and it is a good medium for growing bacteria. And these bacteria and viruses can easily be transferred to the personnel and other patients. So the whole environment must be controlled. Beside that, we open the skin during the surgery, and we expose the deeper tissues to the outside environment. This outside environment, which is the environment in the operating room, must have a condition that does not increase the risk of infection in these exposed tissues. So how we control it? First of all, temperature. Temperature is very important. It must be kept between 68 to 75 degrees of Fahrenheit, but this is not the rule. This is the most appropriate one. The temperature is determined by the surgeon. Some surgeons prefer cooler rooms, like me. Uh, During the surgery, the room that I was in was like a refrigerator. It was freezing, but I liked it. But some surgeons prefer a little bit warmer, but this is a general temperature. If the temperature is too low, it's not good for patient. The patient must be warmed because the patient is anesthetized and the patient cannot control the body temperature. So we must control his or her body temperature. Otherwise, there will be hypothermia. Or if the temperature is high, the people will have excessive sweating, and this sweating uh, will ruin the sterility. So we need to control the temperature. Also humidity. Humidity must be between 30 to 60%. If there is low humidity, some electrostatic discharges will happen, and it may damage the equipment, and also it may harm the patient. If we have excessive humidity, wherever we have excessive humidity, it is suitable for bacterial growth. Not only bacterial growth, for fungal growth, and it is detrimental to the sterility of the operating room. So we need to control the humidity. We need to control the air quality and floating objects, I mean, tiny objects in the field. It must be, it may be dust, or it may be bacteria or viruses. So we need high efficiency particulate air filtration system to remove these airborne particles. Another thing that is very important in the operating room is positive pressure systems. You are familiar with positive pressure systems. Inside an apartment or inside a room or operating room, it has a pressure a little bit higher than outside. And when you open the door, the air flows outside. So nothing can enter, I mean, nothing by air can enter this room from outside. You can enter, but nothing can flow inside. For operating room, it is very important to have positive pressure system to prevent the contaminants in the outside environment to enter the operating room. And also the air system in the operating room must perform frequent air exchange up to 20 times per hour to keep the air quality acceptable. Inside the operating room where the surgery will be performed, not the other parts, unrestricted area and semi-restricted. In those areas, uh, whatever I mentioned up to now about the high pressure, positive pressure, and high efficient filtration, it applies to all parts of the operating room, semi-restricted, restricted, and unrestricted. But in restricted areas, we need something called laminar airflow. Laminar airflow means the air inside the operating room in the restricted area flows in laminas, in several layers. We have two major laminar flow. One is unidirectional or vertical. The other one is horizontal or multi-directional. We have a third option, which is turbulent. Unidirectional or vertical one is the most efficient one and is the most expensive one, and is usually used only for specific subspecialties like orthopedic surgery and neurosurgery, organ transplant, that strict rules are important in sterility. In unidirectional or vertical airflow, the clean air enters the room from the ceiling just above the operating table, and it flows downward and then moves away and leaves the room through the walls, the lower part of the wall. Or sometimes it can move back toward the ceiling, but usually through the lower part of the wall. So since the air that is entering the room is clean, there are no microbes in this air, and it flows over the operating table and the surgical site and the wound, and then moves away. So the risk of infection is lowest here. In horizontal laminar airflow or multidirectional, from all around the room in the walls, the air is blown toward the operating room, operating table, and then it is removed through the ceiling. It is associated with more infections, but it is very simpler and cheaper. So in surgeries that we don't have any strict rule, like obstetric ward, like gynecology ward, like ophthalmic surgery, we use these horizontal airflow, and they are effective for these surgeries. We have another one which is called turbulent flow. We have no rule for airflow. They are located based on the design of the ventilation system, not based on the operating table. And they can move in any direction. They are associated with the highest risk of infection, but in some surgeries, like trauma surgeries, we don't need these rules, because in trauma surgery, the field is already contaminated, because the patient comes from the street and the wounds are contaminated already. So we cannot add more to this contamination. So we don't need too much expenses for the laminar airflow for a wound that is already contaminated. That is why we use this simple turbulent airflow in these areas. Another important part in operating room is lightening. Uh, Without lightening, the surgeon cannot perform the surgery, specifically in deep wounds. We have two kinds of lightening in the operating room. One, general lightening, which is the general or ambient light, usually in the ceiling, and they provide the light for the whole room. You can change their intensity, but they are not focused. Uh, they are for the whole room, but you have a task lightening or focused lightening, or you see here, this one. This is for performing the surgery because it focuses on the surgical side, and uh, it doesn't produce any shadow from the head or body of the surgeons and the personnel. So the only shadow may be the shadow of the devices and the hand, and they are small, and they are a very critical part of the operating uh, rooms. Uh, we can use any type of light for these task lights and general lights, but in current operating rooms, we need a kind of light that provide proper color rendering. I mean, it must provide a system of light that the surgeon can differentiate between tissues easily. It should not change the color of the tissues or or be so bright that all the tissues have the same color. The surgeon must be able to differentiate between tissues easily. So previously, we used halogen lights, They were good, but with LED lights, almost all operating rooms are equipped to LED lights for both focus and general, for task and general lights. They are energy efficient. The light is high quality with excellent color rendering. They have a longer lifespan, and one important thing, they produce minimal heat because these lights are very close to the surgeon, usually usually behind the surgeon or above the surgeon head. And if they produce heat, it is very disturbing for the surgeon. The task lights are designed in a way that the surgeon can hold this handle. With this handle will be sterilized, and the surgeon can hold the handle while he's sterile and can move it anywhere he or she wants. So they must be as light as possible. They must have several arms and several hinges to be able to move them around. And also, they must be covered in a way to prevent the dust and bacteria to enter these hinges so they can be sterilized in the room. Also, noise must be kept to minimal. When you enter the operating room, if you are not the surgeon and the operating personnel, the resident and the people who are helping the surgeon in the surgery, you must not talk unless the surgeon asks something. Because every focus in the operating room is on the patient through the surgeon and the surgical team. So if there is excessive noise, when the surgeon needs something, and surgery is a stressful job. And when the surgeon is performing the surgery under stress, if there is a problem and under those stress, he says something and needs something immediately, if there is too much noises, the people around him or her will not hear what the surgeon wanted, and it takes time for their communication, and it will cause complications for the patient. So in operating room, the noise must be kept at minimal. This is what we should do to keep the noise minimal, but in design of the operating room, all the walls, ceiling, and floors must be soundproof and not soundproof, sound absorbing, sorry. And all the devices that cause noise should be repaired to keep the noise to a minimum level. And you may have heard the noises in the operating room. There are some natural noises in the operating room. The monitors that are recording the heart function, and the uh, ventilator that is producing the ventilation to the lungs. These are some ambient sounds in the operating room, and they are enough for distracting the people. An important aspect of the operating room is infection control in the operating room. We must, when we want to enter the operating room, or we want to work in the operating room, we must respect the rules. The rules are there for safety. This safety is not only because of the patient. The safety is for all the people who are in the operating room, the patient, the personnel, the surgeon, the students, for everybody. So the rules must be respected. In an operating room, there are several levels of cleaning protocols. All the operating room must be cleaned. They have some rules. The operating rooms usually have 1 day for general cleaning. On that day, for example, on Fridays, on Saturdays, 1 day a week, they have general cleaning. Every aspect of the operating room will be washed. And after each surgery, the specific operating room that the surgery was there will be cleaned thoroughly, and everything that was used must be cleaned. All the surgical tools in the operating room must be sterilized, even if they are single use. Um, Hand hygiene is very important. If anybody wants to enter the or approach the surgical sterile field, hand hygiene is a priority and is a necessity. In the semi-restricted area and in the restricted area, mask, hat is necessary. In restricted area, gown is also, a sterile gown is necessary, and so on. The patient that wants enter the operating room, because the patient is the center of the sterile area. The patient is on the operating table and the operation is performed on the patient. So if the patient is not clean, the bacteria on the patient will contaminate the surgical field. So the patient must have shower before surgery, and also the hairs must be removed from the surgical area. The hair removal is very strict. Each hospital and each surgeon has some rules for hair removal. Um, the nails must be, if there is any nail polish, they should be removed. The nails must be clipped, and these are the rules for the patient. Um, and also, the people who work in the operating room must have continuous education. They must be familiar with the current rules, and if there is any update, they must be educated. Another aspect in the operating room is waste management, and the people must be familiar with the waste in the operating room. I said operating room, in the operating room, you encounter several hazardous material, blood, chemicals, many medications, and anesthetic agents. So they must be gathered, and sharp objects, very sharp objects. Actually, the sharpest object in the world are surgical knife. So you must be familiar with how they must be handled. Uh, each type of the waste in operating room must be handled separately. For example, blood and infected waste should be handled in a bag with a specific color, and they should not actually the waste, all the waste from the operating room must be disposed in a specific area and in a specific way. They cannot be left behind the road to be picked up by a general system. They must be picked up by a specific car and moved to a specific area for disposal, because it not only contains biologic waste, it contains chemical waste, it contains sharp waste. So each one of them should be separately packaged. For example, for sharp objects, we have a rule. We have some boxes for sharp objects in the operating room, and everything that is sharp is disposed in those boxes. And when the capacity is enough, full enough, they are packed and they are sent to uh, somewhere to be crushed or to be melted, uh, because we don't want to handle those sharp objects. Those sharp objects are contaminated with blood or other body fluids, and if they cut the finger or skin of other people, the workers in those factories, they can be contaminated with viruses and bacteria. So we don't handle those sharp objects from operating room. They will be crushed or melted, and with melting, every bacteria and virus is destroyed, so it is safe. So as you see, there are some protocols for waste management, and the most important part, sterilization. Everything that is used in surgery, in the surgical field, must be sterilized. This sterilization may happen in the hospital or in the company that has produced that device. For example, when we want to use a knee implant, the implant is produced and sterilized in the company, and we receive a package that is sterilized. But for devices that we use during the surgery, the knife, everything that we use for bone holders and devices like this, since they are multi-use, so we have them in the hospital. When we use them for the next surgery, we wash them, clean them, and then sterilize them in the hospital. There are some terms. I don't want you to memorize these terms, but become familiar with the general concept. With sterilization, we mean killing all the bacteria. So when something is sterile, it means it doesn't have any bacteria, any virus, any organism on it. But this infection is used for uh, reducing the load of microbes on the surface of a device in a way that it is safe to use. With this infection, we cannot use the device in surgery, but we can use it in other procedures like endoscopy or skin procedures, because these areas are already contaminated with, not contaminated, they contain bacteria. So we don't need a sterilization for performing a simple procedure over the skin, not under the skin, over the skin, or performing a procedure inside the gastrointestinal system. For endoscopy, the endoscope is not being sterilized. We don't need it. We disinfect the endoscope. And as I said, we have critical items and non-critical items. Critical items need sterilization. Non-criticals only need disinfection. I reviewed the sterilization techniques very fast for you. I explained them in detail here because I just wanted you to have a reference for them, but I explained them very fast. We have two kinds of sterilization, heat sterilization and low temperature sterilization. In heat, we use heat with or without steam and pressure to kill the organisms. In low temperature one, we have an agent that doesn't need heat. Heat sterilization is either autoclaving, which uses saturated steam, which means steam with high temperature under high pressure inside a chamber. This high temperature, which is around 121 to 134 degrees of Celsius, and high pressure can kill almost all the bacteria and all the organisms. It is highly effective. It is the most common method of sterilization for operating room, especially in the developing and underdeveloped countries. But it has some problems. First, it takes time to perform the sterilization, 1 to 2 hours based on the device. And also you need the steam to penetrate everywhere. So the inside the chamber, these devices, the packages that are packed inside the chamber must be arranged in a way to allow the steam to penetrate between them. If they are packed tightly, the sterilization process will not be complete. And also the package we use here must allow the penetration of the steam into it. If we use a waterproof pack, inside the waterproof pack will not be sterilized because the steam cannot penetrate it. Sometimes, especially when we want to use a smaller device, we use dry heat sterilization, which use only heat instead of heat and steam and pressure. It only uses heat, which is higher than the autoclaving, and it takes usually faster, but it has one problem. The problem is high heat, and you cannot do a sterilization on everything with high heat. So if you have plastic, if you have very small glasses, if you have electronic devices, for example, a drill or a saw, electrical saw, you cannot use these techniques for sterilizing them because they have plastic parts and it will be destroyed. And you can also, you can't use them with autoclave because autoclave also may damage them. So you must be careful with this heat sterilization when you are using heat sensitive materials. This is a comparison between these two techniques, but currently, especially in developed country, they have moved to low temperature sterilizations. They have different methods: ethylene oxide, hydrogen peroxide, gas plasma, vaporized hydrogen peroxide, radiation sterilization using gamma or electron beam, filtration, ozone, or chemical sterilization. These are more effective, more expensive, and I said currently the choice are low temperature sterilization. Ethylene oxide is a gas that can kill all the organisms by damaging the DNA and proteins. So we pack the whatever we need to sterilize, we pack it inside the chamber, and we evacuate the chamber from air, and we enter the ethylene oxide, and ethylene oxide penetrates everything and can kill the bacteria and fungus and viruses. Usually it is mixed with nitrogen because we do not use pure ethylene oxide. And the temperature is usually around 50 degrees centigrade, so it is not hot. Uh, so we can use it for heat sensitive material and also heat insensitive material. We can use it for everything. But we must know ethylene oxide is toxic. So when the sterilization is finished, we must give some time to the ethylene oxide to dissipate. So we need to enter some air to the chamber and allow the ethylene oxide to be washed away. Otherwise, it is toxic. We can use hydrogen peroxide. Hydrogen peroxide, when vaporized, can produce oxygen radicals, and these oxygen radicals will damage the cell DNA. So the bacteria and viruses can be damaged. It is very effective, but and the good point is vaporized hydrogen peroxide leaves no residue on the toxic residue on the sterilized item. But to increase the effectiveness of vaporized plasma, which converts some of the molecules of H2O2 into oxygen radicals, we can use plasma hydrogen peroxide. In this technique, instead of vaporizing the hydrogen peroxide, we turn the hydrogen peroxide into plasma. So all the molecules of H2O2 are turned into oxygen radicals. So they are more effective. And it is one of the best ways for sterilization. But at the end, you must be careful because there are lots of uh, oxygen radicals in the chamber and it must be washed away. Otherwise, it is toxic. Radiation is one of the commonly used methods of sterilization. We use electron beam or gamma ray. You are familiar, electron beams cannot penetrate thick objects and they are absorbed because they are low energy. We can increase their energy, high energy electron beam, but still they cannot pass the objects, specifically thick objects. But gamma can penetrate anything and can pass through anything and anything, I mean, surgical devices, anything, not through the walls. So it is much better. These radiations can create uh, radicals, different radicals in the cell, in the bacteria and viruses, and by these radicals, they can damage the nucleic acid or DNA, or they can directly damage the nucleic acid and kill the cells. Gamma radiation is like a reactor, so it cannot be present in the hospital. It is usually in a large nuclear station or somewhere with a nuclear center. So it is like a reactor. Gamma radiation is produced by a nuclear reaction, and this gamma radiation is can sterilize the package that moves through the chamber. It is very fast. It is very effective. And currently, most of the implants, most of the devices that are produced by the companies are sterilized by this method. The only material that um, we prefer not to sterilize with gamma radiation is polyethylene. And when we discuss polyethylene later, we say why. Other materials in biomedical engineering can be sterilized with gamma radiation, and it is perfect. And when finished, when the sterilization is finished, no radiation remains on the items and they can be used immediately. The same thing happens for electron beam. We use high energy electron beams. It is safer for personnel because gamma radiation is very dangerous if they leak, but beta radiation are safer. But as I said, they are absorbed in thick objects, so they can be used only for thin or flat materials like different films or plastics. Um Another method of sterilization is filtration. Filtration is used for liquids. We cannot use different methods for sterilizing the liquids. We cannot use autoclave or dry heat because it causes boiling and destroys the liquid. Some irradiations may change the chemical structure of the liquid, especially in pharmaceutical companies when they have produced a drug, a medication, and they want to separate two molecules without changing their properties. The best way is finding their size and using the filtration to separate them. And also, we can separate the bacteria, viruses, which are larger than the molecules of the medications from the medication. So in this way, we can sterilize the medications for being used in uh, different injections without using radiation or heat. Simply, we separate the bacteria with filters from the other molecules because their size are completely different. You can see grass comparison of the size of the human cell, bacteria, viruses, DNA, and other molecules. So uh, you remember DNA is a huge molecule. The molecules of medications are usually in this range, in the lower part of this scale. But bacteria, viruses are in the middle, so we can easily separate the bacteria from the drug molecules very easily with filtration. We have two kinds of filtration system. One is depth filters and the other one is membrane filters. Membrane filters are thin, but and they are usually formed by polymeric or ceramic material. But depth filter are like um, a porous matrix. They have a bulk, and the material passes through this bulk and through the pores. And the size of the pores determines which molecules remain in the bulk or in the filter, or which molecule pass through it. And very easily, based on the size of the pore and determining the size of the pore, the molecules can be separated, or the bacteria and viruses can be separated. We can use ozone with the same mechanism as hydrogen peroxide, but the good thing for uh, ozone is it has a small device and it can be produced in the, for example, clinic, in the room that you are examining the patients at the same location. It is very simple and it can be used easily in the clinics. It is not as effective as hydrogen peroxide, but it is effective for general use. And we have a chemical sterilization, which is very common in the surgical field. Sometimes you have devices that you don't have time for re-sterilization. For example, you have a grasper, a metal grasper, and you are using it and finally drop it. If you want to send it for a sterilization, it takes at least 1 hour, and you don't have time to wait for it. You don't have a replacement for it. So the best way is for that single device, you use chemical sterilization. You have um, chemicals like peracetic acid or hydrogen peroxide. There are some devices for them that you can immerse the item you want to sterilize into in the liquid, in the chemical that sterilizes that item. But in the operating room, it is very simple. They use a bucket, a large bucket. They pour the chemical, usually hydrogen peroxide, inside it, and they put the item in the hydrogen peroxide and immerse it and cover it for 15 minutes. And after 15 minutes, it is sterile, but it is not fully sterile. It is sterile enough to be able to use it in a surgical field for a short time, so you can perform the surgery. When we use the sterilization techniques, we must be sure that they have killed the bacteria. Otherwise, we are using those items and we don't know that the bacteria and viruses are killed. So they will grow in the surgical field and they will cause infection. How we become sure that these sterilization techniques are working? We have two major techniques. First, we can test the system for to see if any bacteria, any virus, anything is still present in the sterilized item. Or we can check the function of the device. For example, in autoclave, we know the device might reach to a certain temperature, certain pressure for a certain time. If these criteria happened, we must say the device works correctly. So we have two approaches. One, checking the functionality of the device. Two, checking the presence or absence of bacteria in the sterilized item. So to check for bacteria, which is more accurate because we are sure that the bacteria are dead, we have, again, two options. We can open the item, which is sterilized, packed, sterilized, and now we can open it and take a sample and send it to the lab to see if a bacteria grows. But it takes 48 hours at least. So when I want to perform the surgery, I receive a package of surgical instruments, I open it, and I send the sample to the lab for bacterial growth. I cannot wait 48 hours. I have to use it now. So it is not practical, but it is the most accurate one. And it is used for checking randomly to see if the device, the autoclave or gamma irradiation system is working correctly or not. So it is for random checking of the functionality of the device, but it cannot be used for checking the current item. Because I want to use the current item now. The second way is using an indicator, which can be biological indicator. When we put the items in the machine for sterilization, based on the technique, we can have a biological indicator beside those items. And when the sterilization is finished, you see here, This indicator has several parts. One part contains some bacteria. These bacteria are the most resistant bacteria on the earth. So if the sterilization technique can kill those bacteria, it can kill any other bacteria, okay? So we put those resistant bacteria in this container. This container allows the penetration of the sterilization system. If it is heat and pressure, it allows heat and pressure penetration. If it is gamma irradiation, it allows gamma penetration, okay? So it differs between different systems. Inside it, there is the bacteria and also a closed container containing a medium for growing this bacteria, this resistant bacteria, but it is closed. It is not in contact with the bacteria. And the whole system is closed like this. So you put it inside the sterilization device beside your items. At the end of the sterilization, the bacteria around here is either totally killed or it's still alive. At the end, to make sure if it is alive or dead, you break this inside chamber and release this medium to allow the bacteria around here to grow. If the bacteria is alive, it grows. If the bacteria is dead, no growth happens. When the bacteria grows, there will be a change in the color and you will know it. It usually takes several hours, but it is very sensitive. It cannot help you for immediate decision, but it certainly tells you if the sterilization technique was correct. And if it was not correct, it will tell you that the device you used was not sterilized in a few hours after the surgery. Few hours means that the infection hasn't happened in the patient. So you have time to do something for the patient. You can perform the surgery again, clean the surgery, or you can give antibiotics to the patient. So you have time to treat the patient for infection. But if you want to become sure when you want to perform the surgery to see if the package item is sterile, you have another option, and that's chemical indicator. These are some chemicals that, based on the technique of sterilization you are using, when all the conditions necessary for sterilization is fulfilled, this chemical indicator changes in color to a specific color. For example, to green or to black here. For example, this is for autoclave. When the criteria for sterilization in your autoclave has reached to what you have in mind, this change happens. If you have a chemical indicator for gamma irradiation, when the amount of gamma irradiation reaches the necessary amount, this change happens. So you are not sure that there is no bacteria, there is no virus, because these indicators doesn't show the number of viruses, alive viruses or bacteria, but they tell you that the process of sterilization was correct. And you know, if the process is correct, it will kill all the bacteria and viruses. So indirectly, you know that the device is sterile. This chemical reaction tell you immediately after the process of sterilization that the sterilization was correct or not. You can do the same thing with some sophisticated devices on the sterilization machine for like sensors or monitors to see if the pressure has reached the intended amount, the temperature has reached. But this indicator tells you immediately, specifically when you put them inside the packages and you see the changes has happened, you are sure that inside the package is sterile. Especially for large packages, for example, the patient covering during the surgery, they are usually packed in large packages. So if you want to be sure that the middle part and the inside part of this large package is sterile, you put some of this chemical indicator in the middle. And if the change in color happened, you are sure that that part is sterile. So when middle part is sterile, so the surface is definitely sterile. Okay. Any question? No? Thank you for your patience. This session was too long, but I think it was interesting about the operating room. Especially, you must be familiar with the conditions of operating room when you go to the hospital. We will discuss more about operating room. We will discuss about the hand sterilization technique, hand sanitization in operating room, how to respect the operating room sterility, the field of sterility, define the field of sterility. We'll discuss all of them. So when you enter the operating room, I want to make sure that you are familiar with everything. But this was the beginning. So have a good weekend. If you have no question, have a good weekend, and see you on Tuesday, because on Wednesday on Monday we don't have any research meeting. Okay, correct?
Yeah, quick question.
Surely.
So when we present our research in like a couple of weeks, do you want it to be like a PowerPoint, like an actual presentation, or?
It depends on you. If it is a PowerPoint, it is easier, I think, but it takes time and you don't have time. It depends on you. I have no obligation for it must be PowerPoint or not. The important thing is how what you present, not how you present.
Okay.
Okay. So see you on Tuesday at 6:30 and enjoy your weekend.
Have a good weekend.
Thank you, Professor. Have a good
Thank you.
weekend.
Have a good weekend, Professor.
You too.
Bye.
Bye.